We're going to continue on with Chapter 8 lab notes, moving on to Part 3, which is going to cover the axial skeleton, specifically the vertebral column and associated bones. Now, just a reminder that the axial skeleton consists of the skull, the vertebral column, as well as the thoracic cage. And again, the axial skeleton here is highlighted in that kind of sea green. Other bones associated with the axial skeleton within the skull would be the auditory ossicles. Now we are going to go over the auditory ossicles in more detail when we get into Chapter 16. So just as a slight review here, the three auditory ossicles we have form the smallest synovial joints in the human body, and they are called the malleus, incus, and stapes. And this is a fair representation of the malleus, incus, and stapes and how they compare to the size of a penny. Now, the next associated axial bone will be the hyoid bone. This bone does not actually articulate or connect directly with any other bone. It does have connections via muscles and ligaments, but not bone to bone. This is a bone that is most often fractured when somebody is manually strangled. So on this view here, we're looking at the hyoid bone on X-ray, and this view here shows the hyoid bone as it sits superior to the thyroid cartilage. For our lab purposes, we're just going to identify the hyoid bone, but if you were interested, there are some landmarks. We have the greater cornu, or sometimes it's referred to as the greater horn. We also have the lesser cornu, which is also referred to as the lesser horn, and then the body of the hyoid. From a side view or lateral view, you could see that the greater horn creates this back leg here, and the lesser horn or cornu creates that little tooth-like appendage that sticks up. Again, for our purposes, we just need to know that it is the hyoid bone. And this will be the picture that we have in our lab manual. And just in case somebody needs to go into greater detail, we have the alternate names, the greater horns or cornu, and the lesser horns or cornu of the hyoid bone. We're going to talk about the fontanelles. Now, the fontanelles are considered to be the soft spots on a baby's head, and you're most likely going to be familiar with the anterior fontanelle. Now, you might notice as we go through the slides that the spelling changes a little bit. The English version of the word fontanelle is spelled with two L's and an E to follow. The American version of fontanelle is spelled F-O-N-T-A-N-E-L, and so we're going to see the American version on a lot of our slides. We can see from the superior view and the lateral view that there is more than one fontanelle. The main one is going to be the anterior fontanelle. That's the one that we see most often and we pay attention to. The next one would be the posterior fontanelle, but there are smaller fontanelles off to the side that we see, the sphenoidal fontanelle as well the mastoid fontanelle. The purpose of the fontanelles is to allow the cranial bones to slide a little bit underneath each other so that when the baby's fitting through the birth canal, the head actually fits. And then when the baby comes out, those cranial bones will kind of move back into place if everything's normal for the baby. Now, sometimes the bones don't move so well, and then the baby's head gets a little bit stuck in that position, and that can lead to problems for fetal development. So if there's a case like that, usually those individuals need to be seen by a craniosacral therapist or a medical doctor, and they wear the little helmet that helps try to reshape their head so that they're have equal development. This would be an example of our model that shows the anterior fontanelle. The model has now been turned 180 degrees, and we see the posterior fontanelle at the back. Now the child's skull has been turned laterally, so we're looking at the lateral aspect, and we see the sphenoid fontanelle here, as well as the mastoid fontanelle through here. And then you can see actually on this particular model, this little crevice or crease right here, that is called the metopic suture. For a baby, they actually have a right and left frontal bone that then fuses together, usually by the age of 4, and it's no longer existent in us adults. And so that is the precursor to the full frontal bone that we have. And again, you see that anterior fontanelle. We're just going to look one more time at a slightly different model of the anterior fontanelle as well as the metopic suture. Again, keeping in mind that this is an example of the American spelling of fontanelle. If we're looking at the English spelling, it would be Fontanelle. Both versions are considered to be correct. Now we're going to move on to the vertebral column. The vertebral column will be made up of 24 freely movable vertebrae, as well as a coccyx and a sacrum. And so that gives us a total of 26 bones that make up the vertebral column for an adult. This is just showing you the different views of the vertebral column. What we're seeing here is the posterior view. Notice that the posterior view has all these knobby, sticky-outy little pieces. Those are the spinous processes of the vertebra that you can feel when you put your hand on the back of your neck. Now this is the side view, the lateral view, and you can still see the same sticky-outy pieces. On the anterior view, we're seeing the vertebral bodies here, and they are very smooth because you don't really want anything sticking out when you have blood vessels and nerves running along this area. We can break the vertebral column down into 5 divisions. The first one is the cervical region, then we have the thoracic, followed by the lumbar, then we have the sacrum and the coccygeal area. They're going to be designated by a letter, a capital letter followed by the number. So if we look in the cervical region, we see that there are 7 cervical vertebrae. There's going to be 12 thoracic vertebrae, 5 lumbar vertebrae, 1 sacrum, and 1 coccyx. And this slide here just shows what we spoke about on the previous slide. A little bit nicer writing. Keep in mind the stylus I'm using is attached by the mouse and it doesn't give me good cursive or writing abilities. Now we're going to look at the cervical vertebra, and what we're going to see is that there are vertebrae that have very similar features. We call those typical cervical vertebra, and then we'll have 2 cervical vertebrae that have very distinct features that are not found anywhere else in the cervical spine. That would be C1 and C2. So C3 through C7 will have very typical presentation when we look at their surface features. And the highlighted area here is just showing you the cervical region. Now this is a lateral cervical view. I want you to take note that in the lateral cervical view we also can see the sella turcica. In order to be relevant from a medical perspective on a lateral cervical view, we must include the sella turcica as well as C7. And any x-rays that don't have those included, if they're a specialty shot, okay, but if they're supposed to be a medical x-ray, it should have these landmarks in order to be considered of adequate quality. Now when we look at the thoracic vertebra, as a general rule there are 12 thoracic vertebrae, and off of each vertebra there will be a rib, usually 2 ribs. So each vertebra will have 2 ribs that come off of it. Now occasionally we have some congenital anomalies, and somebody may only have 1 rib coming off of their thoracic vertebra, or they may have no ribs coming off of a certain segment. Those are anomalies. So as we look here in the thoracic region, we will see that it actually serves as the basis for the thoracic cage to come off. As we see, there's 12 ribs that come off on either side on this individual. Now here we're looking at an aerial view, so we're looking down onto the thoracic vertebra, and I want you to take note that its vertebral body, this area right here, is kind of heart-shaped. This is just an A to P view showing you the thoracic cage. Now part of the thoracic cage, or the thoracic spine I should say, is being covered up by this structure here, which we will talk about in a few slides down the road, and we'll learn that this is called the sternum. The lumbar vertebra are in the lower part of the back. There are 5 lumbar vertebrae. They are kind of the workhorse vertebra. They support a maximum amount of weight, much more so than, let's say, the cervical vertebra, which supports the skull and its structures. And so you can see just below the thoracic vertebra we have the lumbar vertebra here, okay, and they have these big, long, sticky-outy processes called transverse processes. The other thing I want you to note is how big the lumbar vertebral body is. It's very big so that it can really hold up to supporting the weight of our torso and our upper extremities. Now this is a nice x-ray shot of somebody's lumbar spine, and it's showing you a couple of landmarks that we're eventually going to get to. But what I'd like you to take note of is how clean the vertebral body is. It's nice and squared off, and there's not a lot of jaggedy things. If we saw some big jaggedy things coming down and big jaggedy things coming up, that would be a sign of osteoarthritis or degenerative joint disease. The sacrum is an area of the vertebral column that when we're young, in our early 20s and prior to that, we would see that there's a potential for 5 segments that have not yet fully fused together. After our mid to late 20s, we should be fully fused at that time, and that sacrum should be one full piece. Now, there are some individuals who have what's called a rudimentary disc between S1 and S2 because their sacrum did not fully fuse. We're seeing a little bit more rudimentary disc show up in our young individuals of today because they're leading a more sedentary lifestyle with their video game and Game Boys and Xbox playing. And so really, in order to form properly, we have to put these segments under duress. They have to be exposed to weight-bearing activity in order to fuse the proper way. So this potentially could lead to more back pain issues for the younger generations coming up the line who are less active. So this is the sacrum, and we can see that it's fused together. It looks like it's one complete unit. The sacrum also will articulate with the pelvic bones on either side to form the sacroiliac joint. We'll look at that on the appendicular skeleton PowerPoints, but I just wanted to give you a little preview there. Now the last bone that we're going to talk about very briefly is the tailbone, or the technical term for it is the coccyx. You might have heard that the coccyx is not very important and you could live without it, and technically you could, but the coccyx, when it is not moving properly, and it should just move slightly, it can cause a lot of back pain issues, a lot of pain for people to sit down. So the tailbone should not be taken lightly. And you can see highlighted in green here at the apex of the sacrum, the coccyx. Now this chart just brings back to your mind the different areas of the spine with the cervicals, thoracic, lumbar, and sacral regions, and it talks about the different curvature. So if we look at the cervical curvature and the lumbar curvature, they curve the same way. The thoracic and the sacral curvature curve in an opposite direction. These 4 spinal curvatures are very important because they, when they're curved properly, will help give us support and flexibility to the spinal column. The cervical curves can be seen best in the lateral view. If we were to have a curvature in the anterior or posterior view, that would be an abnormal curvature. You might be familiar with the term scoliosis. That is a lateral curvature. It's not something that we really want to see on X-ray. Now the thoracic and sacral curvatures will be present when we're born, and that's because when we're in utero, in the womb, we're flexed forward in order to fit into that area. Now the cervical and lumbar curves are considered secondary curves. These are what develop as the child starts to grow and age, and basically these develop when the baby's put down on his crib or a blanket on the floor and you lay them on their back. So what you do is lay them on the back, and then eventually they learn how to turn themselves over, and then as they do that, they push off with their hands and their head up so that they don't suffocate. And that's how they start to develop that cervical curve. Now that's the first one, which is good because you don't want your baby to suffocate. And then the lumbar curve starts to appear when the child gets more weight bearing. And so when they're learning to stand and walk and move around on their own, that's when the curve appears. The thing that you want to try to avoid is accelerating that lumbar curve presence. And you would accelerate it by putting the child in an upright weight-bearing position. So when you see them straight up when they're too young, that lumbar curve is put under duress at a younger age and they're not really developed enough to support it properly. And in my opinion, that's one of the things that can cause scoliosis to occur. And so just looking at this again, we look at the primary versus the secondary curves. Again, primary will be the thoracic region and the sacral region. Secondary will be the cervical and the lumbar region. Now, sometimes people will have an exaggerated thoracic curve. We call this In the textbook, it's called kyphosis. In clinical setting, we would usually refer to this as hyperkyphosis. So it's exaggerated even more than what would be normal, and that'll give you that hunchback look. And this is not good for an individual. Now, if somebody had a lumbar curvature that was exaggerated, the term that the textbook uses for this is lordosis. Again, in a clinical setting, we would call this a hyperlordosis, and that would be seen on individuals who have really weak abdominal muscles or potentially some type of compression fracture. You definitely see a hyperlordosis on pregnant ladies. And then we've mentioned before the scoliosis, which is a lateral curvature. Those, again, are not considered to be normal. So this is a representation of the abnormal curvatures. If we look at it, we see that graph C is representing the kyphosis, B is representing the lordosis, and A is representing the scoliosis. Just keep in mind that exaggerated curvature in a clinical setting usually has the prefix hyper associated with it. So it's hyperkyphosis or hyperlordosis. And just a quick look at some of those curvatures here. And so on this slide, we're looking at some more lateral curvatures called scoliosis, and you can see they can occur in the thoracic spine or in the lumbar spine, or you could have two, one in the thoracic, one in the lumbar. They can also be present in the cervical region. So now we're going to look at the typical vertebral anatomy. Most of the vertebrae within the vertebral column will have these features. So we're looking at a thoracic vertebra, and what we need to take note of is the thoracic vertebra has a heart-shaped vertebral body, and it has two little legs that come off on either side that then connect with another bridge here, and that creates the vertebral arch. The vertebral arch will then create this hole that is seen right here, which is called the vertebral foramen. And we'll see that it has two outward sticking pieces, and the word used to describe things that move off to the side or outward is transverse or lateral. So we'll use the word transverse process here. And then at the very back, we're going to have this sticky outy piece that we can feel when we get a back rub or get somebody to touch our backs, and that's called the spinous process. Now on this view, we're actually looking at a lumbar vertebra, and it has the same vertebral body that we saw before. It has the same vertebral foramen. It has the same vertebral arch that forms that vertebral foramen. It does also have two transverse processes that come off, as well as the spinous process that sticks out. We're going to add a few more areas to look at. On the lumbar vertebra as well as the thoracic vertebra, we see this short stumpy leg that comes out. That's called the pedicle. Now that's not on your needs to know list, but I like to bring this up to you because when people have a spinal fusion, one of the areas that they screw the screw into or drill the screw into is the lumbar pedicle in order to fuse the spinal segments together. Now we're looking at a superior view, and on the superior view as well as the lateral view, we can see this upward projection. This one's coming up at us and this one's going up in front of us. That is called the superior articular process. Now if we have a superior articular process, by default we will also have an inferior articular process. And that one is best seen on this lateral view right here. The thoracic vertebra also has an inferior articular process, but it's kind of hidden by the actual spinous process here. On this view, we can also see the spinous process for the lumbar vertebra and the spinous process for the thoracic vertebra. On the lumbar vertebra, we can see the superior articular process peeking out over here as well as coming up at us here and here. And again, just another look at the lumbar vertebra, and it's pointed out a little bit different than before. We see the superior articular process coming out towards us on both sides. And these are set at a 90-degree angle to the lumbar vertebral body. And just showing you that superior articular process one more time. Now, on the smooth side of the process, the actual piece that actually articulates or touches up against another bone. We have a very specific name for this area, and it's called the superior articular facet. So the facets would be on the inside, and that's what articulates with the other bones, and then the outside over here is the actual process. And so to be technical, it would be the superior articular facet of the superior articular process. Now, when the vertebrae are stacked on top of each other, so we have one vertebra stacked on top of another vertebra with a disc in between, we would see that between the superior process of one vertebra and the inferior process of the other one, we would have a space over here. This space is what's known as the intervertebral foramina or intervertebral foramen. We can see the intervertebral foramen where all these little green dots are. Now those green dots would actually be the beginnings of the spinal nerves as they're coming off of the cord and leaving the vertebral column. So you really want to see lots of space here in the intervertebral foramen because that gives more room for the nerves to travel out. The next typical structures that we'll see, I've mentioned before, the spinous process, the transverse processes, the inferior and superior articular processes, and then the facets. So we're just going to revisit those. We will also look at the intervertebral discs. Now this is important because this is what you hear people herniating. They herniated their discs. And basically what's happening is that there's some tears going on in the annulus fibrosus. That's the outside fibrous cartilage area. And part of the nucleus pulposus is leaving. And so I liken this to a jelly donut. So the donut piece is the annulus fibrosus, and the jelly inside is equal to the nucleus pulposus. So when you squeeze down on that jelly donut and there's an opening there or a tear there, some of that jelly is going to get onto the outside. Now we're just revisiting this superior view again of a thoracic vertebra. Again, note the heart-shaped vertebral body. It has much longer transverse processes. The other thing that we would see is that it's a relatively small vertebral foramen through here. In a lateral view, we're looking at the lumbars here, and we can see that we have the intervertebral foramen present, so nice big hole that's formed. The way the foramen is formed, again, is the pedicle of the lumbar above plus the pedicle of the lumbar below and the disc. So when people start to lose disc height, that foramen, so if this disc starts to shrink because it's drying out and it's starting to wear away, what will happen is that foramen will start to get smaller. And that's when people start to have a pinched nerve sensation. Now we're looking at the lumbar spine, and you can note that the spinuses are kind of broad and flat. You can see the width of the spinous is not very much here. It would be the same width as maybe pinching your nose with your thumb and your forefinger. Now we will see that as we start at the skull, that the vertebra will be smaller and narrower, and then as we move down towards the pelvic region, that the vertebra will get wider and thicker and bigger, and that's because they are increasing the amount of weight that they bear. Now, if we can compare the cervical, thoracic, and the lumbar vertebra, we see that they have very similar structures. They have the spinous process, they have the transverse process, they have the vertebral body, they have the superior articular process and facet, they have the vertebral arch with the vertebral foramen, the only thing that the cervical vertebra has that the lumbar and the thoracic vertebra does not, and all cervical vertebra have it, they have something called the transverse foramen. The transverse foramen are very important in the cervical spine because they allow the vertebral arteries to go up into the skull, and that's an alternate source of blood flow to the brain. So the transverse foramen, very important, they are found on all cervical vertebrae, whether they're typical or atypical. Just to recap, the cervical vertebra will all have transverse foramina. C1 through C7 will have a transverse foramen found within the transverse processes. Now we're going to look at something called an atypical vertebra. The first atypical vertebra is C1, also known as the atlas. C1 will articulate with the occipital condyles, and this will allow for the yes-no motion. We call that flexion and extension. The thing that you're going to need to identify on C1 that's different than the rest of the cervical vertebra is something called the lateral masses. When you look at this picture, you see that C1 is a ring, and it has a sticky outy bump in the front called the anterior tubercle. We're not going to ignore that for ID purposes, just giving you some information. And it has the posterior tubercle. It does have a transverse process, so that's typical. That's the same thing that we see elsewhere in the vertebral column. It has a transverse foramen that we only see in the cervical vertebra, but it also has this big mass here on either side that's going to articulate with the occipital condyles. That is called the lateral mass. You do not need to memorize the superior articular facet of the lateral mass. I just want you to keep for your list the lateral masses. And again, on a real model of a vertebra, of C1 vertebra called atlas, we have our lateral mass on the left, and the lateral mass on the right. We have a transverse process, yes, you need to identify that, as well as a transverse foramen on both sides. And again, just looking at our lateral masses, our vertebral foramen, just like we had elsewhere in the vertebral column, we have the transverse foramen found only in the cervical spine, and the transverse process. Now the next atypical vertebra is called axis, or C2. One of the major things that you need to know about C2 is the dens, or also known as the odontoid process. This creates a pivot joint with atlas, and allows us to give the no movement. So our turning of the head right and left is between the atlantoaxial joint, the atlas, and axis. And so here we're looking kind of at a posterior superior view of C2, also known as axis. For the lab exam, I prefer you call it axis. This upward projection here that kind of looks like a tooth, that is the dens. Now this segment, which is atypical, has many of the same features that we saw on the typical vertebra. It still has a vertebral body, but it's a little bit different because it has that dens coming out of it. It has the superior articular processes on the right and left, the inferior articular processes, the spinous process, but look at that spinous process. It's split in the back. We call that a bifurcation, and we see that commonly in the cervical spine. Then we have the transverse process over here, as well as the transverse foramen and the vertebral arch with the vertebral foramen. And so we can look here again on this particular view, and all of those items that we had seen on the typical vertebra are also present on the atypical vertebra with the addition of the dens. Now this is just a quick little look to see how the atlas rests upon the dens, and you can see right through here is where we're going to have our axis of rotation, where the atlas is actually attached by this transverse ligament across the dens, and that creates the ability to swing the head left and right. And just another representation of it. Okay, so we have the lateral masses of atlas here, which is what the occipital condyle will sit upon. We have the dens, which helps form the pivot joint between C1 and C2. The lateral mass of atlas will also articulate with the superior articular facet of the superior articular process of C2. We see the C2 spinous process. We see part of the transverse process, and we see the transverse foramen of C2 and the transverse foramen of C1, as well as the transverse process of C1. And this is just a CT scan of the atlas axial view. We're looking to see if there's a big space through here. people with psoriatic arthritis or Down syndrome, their transverse ligament is a little unstable, and so that can increase the space through there, which would be a sign of instability and not good. Even though it's a typical vertebra, C7 is many a times considered the vertebra prominens. That means it's the most prominent spinous process of the cervical spine. It's kind of that top sticky outy point at the base of your neck. So it's kind of a landmark for clinicians to use in order to count the vertebra. So on this view, you can see that the posterior spinous processes of the cervicals above it end, and that C7 tip projects further than the thoracic spinous process as well. So just review in your book this typical chart of the typical characteristics of the cervical, thoracic, and lumbar vertebra. Now this is a cervical vertebra, but it's starting to look like a thoracic vertebra. Thoracic vertebra tend to have long, thin spinous processes. And so you still know that this is a cervical vertebra because only the cervical vertebra have the transverse foramen. This is just a side view or lateral view of a typical cervical vertebra. So now we're going to move into the thoracic vertebrae. Vertebrae again is plural, vertebra is singular. The distinguishing thing that we'll see with the thoracic vertebrae is that heart-shaped vertebral bodies. They will also have an additional facet. We talked about the superior and inferior articulating facets, but the thoracic vertebrae also have what are called costal facets. That is the area where the ribs attach to the vertebral body and to the transverse processes. Okay, the only one that's really lacking a transverse costal facet would be T11 and T12 because those are floating ribs, and we'll see those in a few minutes. So in your book you have a picture with the characteristics of the typical thoracic vertebra. And what we're going to do is look at the vertebra from the side and from the superior view. It's a little crowded on this screen, but just again take note. We have the vertebral body, and at the superior aspect of the vertebral body we can see a costal facet, and there's a little glimmer of a facet down here. And then we also have a transverse costal facet seen on this transverse process here. We have the typical superior articular process and the inferior articular process and the spinous process. We've already mentioned that this is a transverse process. We can see the aerial view of this same transverse process over here. We see the spinous process is thin and long, and again that heart-shaped vertebral body. Now we're going to move on to the lumbar vertebra. Again, typically there are 5 lumbar vertebrae. Their body is much thicker and more oval shaped because it's going to be weight bearing. We do not see transverse foramina or costal facets in the lumbar spine. So this is the chart in the book with the typical characteristics of the lumbar vertebra, and again they are the same characteristics that we see elsewhere in the vertebral column. This is our superior view of the lumbar vertebra. We've gone over many of these points before. So just to reiterate, we have the vertebral body found here. We have the vertebral foramina found here, which is formed by the vertebral arch. We have the superior articular facet of the superior articular process. We see the spinous process, which is broad, flat. Then we have the transverse process on either side. And that's about it. From a side view, again, we can see the vertebral body. It looks like a nice square body. This is the top half of the intervertebral foramina, and this will be the bottom half. And what we would see is a vertebral disc and then another lumbar vertebra underneath this. And that's what would form this intervertebral foramen through this area here, where the nerves would travel out. We see the transverse process here. We see the superior articular process. On this view down here, the inferior articular process is here, but what we're seeing of it is going to be the inferior articular facet. That's what's getting colored in right now. Okay, and again, that spinous process is broad and flat. Now for the sacrum, you don't need to know many specific landmarks, but we're going to start off with apex and the base. Now the base is actually going to be at the top, which is kind of different than normal. So this is going to be the base, and this will be the apex. Base, apex. On this view, we're looking at the posterior aspect of the sacrum. And over here, we're looking at the anterior aspect of the sacrum. And the biggest thing that you need to pick out about sacrum is this area here, which is going to be the sacral ala. It's kind of the wing of the sacrum. And we also need to be able to pick out the sacral foramina, the holes found on either side. And then from the side view, and you can get a little bit of it right over here on this particular view, we're going to see the auricular surface of the sacrum. We'll show you a better view of that in a few slides. This next set of information is not going to be on your exam in terms of identification, but I want to just show you the superior articular processes. The superior articular processes are what's going to communicate or touch up against the inferior articular process of L5. And so that creates kind of a stability section here. So not a lot of rotation is going to go on at this joint because of these processes. So just to list again some of the things that we need to find on the sacrum, we're going to look for the sacral foramina, we're going to find the ala and the auricular surface, as well as the base and apex. On this view, you can see the base and apex noted, as well as the sacral foramina. And again, the base or sacral promontory, which is found at the base of the sacrum, the sacral ala, and the sacral foramina. Now, this is specifically talking about the anterior sacral foramina as opposed to the posterior sacral foramina. It's still, in general, the sacral foramina. So for our purposes on the exam, I'm just going to be happy if you know it's sacral foramina. I don't care that you tell me whether it's posterior or anterior. Now this is the view that shows us the auricular surface of the sacrum. The auricular surface of the sacrum is actually shaped like an ear. And another word for ear, or the outermost portion of the ear, is called the auricle. The last segment of the vertebral column that we're going to talk about is going to be the coccyx. Usually there's 3 to 4 coccygeal vertebrae that need to fuse together to form one full coccyx, and that usually finalizes in the late 20s. And here at the apex of the sacrum, we see the coccyx, otherwise called the tailbone. Now for your lab exam, you cannot call it the tailbone, you must call it the coccyx. And just a quick look at the sacrum and the coccyx. Now we're going to move into the thoracic cage. We talked about the thoracics and the lumbar sacrum and coccyx, but the thoracic cage is going to be divvied up a little bit differently. We're going to see that the cage is actually formed by the posterior thoracic vertebra, by the ribs more laterally, and the sternum anteriorly. The sternum is called the breastbone. Now, for our lab exam, we need to call it the sternum, but the sternum is made up of 3 parts. The top piece of it is called the manubrium. And at the manubrium, there's a landmark that you need to be able to pick out. It's called the suprasternal notch or the jugular notch. Some reference texts call it the episternal notch. The second part of the sternum is going to be actually the sternal body, and the last part of the sternum will be called the xiphoid process. When you're doing CPR, you want to have your hands on the sternal body. You do not want them on the xiphoid process. And so here we are looking at the sternum as its entirety through here, and I'm going to put little lines that marks off the delineation between the manubrium, the sternal body, and the xiphoid process. Now take note of this picture, which is showing the true ribs versus the false ribs, and then breaking it down a little bit further into the floating ribs. So when you're looking at the true ribs, what makes them true is that they actually connect to the sternum. All the way down, their cartilage actually comes up and connects to the sternum. So 1 through 7 all have a sternal connection. Another name for that are vertebral sternal ribs. Now when we look at 8, 9, 10, these connect, their cartilage connects actually to the cartilage of T7 rib. And so we would call those vertebral chondral ribs. The last 2, 11 and 12, they only connect to the vertebra. And so they are called vertebral ribs as a result. So quick point out to the manubrium, the body of the sternum, and the xiphoid process, and then right through here we have that jugular notch or that suprasternal notch or the episternal notch. And just another look at that. Now we've gone over the ribs before, but just a repeater here. Our true ribs are ribs 1 through 7, and they were also referred to as the vertebral sternal ribs. And again, 1 through 7. So we got 1, 2, 3, 4, 5, 6, and 7. Those are our true ribs. And then we have our false ribs, ribs 8 through 12. Now there's two types of false ribs. We have the 8 through 10, which are also called vertebral chondral ribs. They attach to the sternum by attaching to the chondro or the cartilage of the T7 rib. And then we have the floating ribs. The floating ribs, because they only attach to the vertebra of T11 and T12, are referred to as vertebral ribs. Now, an easy way to get a rib count, I'm not going to have you do it with the individual ribs, but I like to use this posterior view, and one can hope that you can count from 1 to 12. And usually I ask questions about name the rib, which number, and what type of rib it is. If it's a type of rib, it's a true rib or a false rib, or it's a vertebral sternal rib or vertebral chondral rib or a floating rib. Then we can get to some specific rib anatomy. All ribs have these identifying features. The identifying features you need to know for your lab test is the rib head, the rib neck, the rib tubercle, also known as the costal tubercle, and then what end is it? Is the vertebral end or is it the sternal end? Basically, if it's attaching to the vertebra, that's the vertebral end. And whether or not it directly attaches to the sternum, it would still be referred to as the sternal end. So we're going to finish on an aerial view of the ribs as they articulate with the thoracic vertebra. And what I want you to take note of is that at the vertebral body, the rib head will articulate, and at the transverse process, the rib tubercle will articulate. The exception to this would be at T11 and T12, where they just articulate with the vertebral body. So this gives us a better understanding of how the rib attaches to the thoracic vertebra. And that will conclude the axial skeleton.